Good morning, students. My name is Josh Burton, one of the emergency medicine residents, taking care of the chest pain component of the COMAT EM Review series that we're putting together. We're going to start off talking about pneumothorax to kick things off. Common complaint on the emergency department typically comes in with chest pain, shortness of breath, and there are two types of pneumothoraces that we see. One of them is a spontaneous pneumothorax. The other one is a secondary spontaneous pneumothorax. So on this one here, so spontaneous, typically see in a young, otherwise healthy individual, nothing really happens beforehand, and they'll come in and say, complain of chest pain, sudden onset shortness of breath. The question stem will usually revolve around shortness of breath on physical exam, loss of breath sounds on one side, and they might show you a chest x-ray that looks like this. Typically in their past medical history on a question stem, they're going to give you some sort of clue to hone you in on this being a pneumothorax, be it Marfan syndrome, history of smoking, and then you'll get your chest x-ray that looks like this. And if you follow these lines here, you can see the outline of the lung here, where you're looking for that pneumothorax. If it's a spontaneous or a secondary spontaneous pneumothorax, typically this is like from underlying pathology. So we see it a lot in COPD patients or iatrogenic. So most common cause being CPR, that's us, which is to be expected during a resuscitation. But again, you're looking for a collapsed lung on one side where you see lung markings through the lung here that you can see, and then you see loss of lung markings. So a big difference between this area of the lung versus this area here. Diagnosis, typically with chest x-ray, right? The ones beforehand are very easy to see. They might try to drop a kind of a different chest x-ray on you, which is this one right here. So this is a supine positioned chest x-ray. And what you're looking for here is something called the deep sulcus sign. So over here on the left side of the chest, you see a normal diaphragm, normal cardiac silhouette. But on the right side of the chest, you see this deep sulci that comes all the way down here. And this is called a deep sulci sign, which is indicative of a pneumothorax. And if you follow these white arrows here, it does a good job of pointing it out to you, but you can actually see the pneumothorax here, following it all the way down. And so if you see a chest x-ray like the ones before, it's pretty easy to get keyed in on what the diagnosis is to make the right answer. But if they give you a chest x-ray that looks like this, know that a deep sulcus sign is indicative of a pneumothorax, and they're probably looking for either tube thoracostomy or something down that pathway. Being in the emergency department, we love using ultrasound. So obviously you can use ultrasound when diagnosing a pneumothorax. Typically what you're looking for is loss of pleural sliding or the barcode sign. So this is what a normal ultrasound of the lungs would look like. We call it C or sands on a beach kind of deal, but this line right here, this is M mode that you put on through the ultrasound, and then you get this kind of sandy appearance through M mode, which tells you that there is lung sliding, that there is not a pneumothorax. If you do your ultrasound and you see what looks like a barcode or something to this effect, which this could be your image clue on the question, saying that, yeah, this person has loss of lung sliding and there's probably a pneumothorax in there. Maybe you can't pick it up on a chest x-ray, but it's present there. Other things you might see would be like absence of B lines, lung rockets, lung comet tail artifact, whatever you want to describe it as, but you won't see those shooting comet tails going down down through the ultrasound view. And if they ask like a most specific sign or what's most specific on an ultrasound for a pneumothorax, it's a positive lung point sign, which is where you'll have lung sliding and then you'll see the loss of lung sliding that goes back and forth. But typically you're going to have this barcode sign that will clue you in to say, yeah, this is a pneumothorax, and they're going to need a chest tube. So to treat these, first step will be place the patient on oxygen. So if the question then reads, what's the first thing you're going to do, or what's the initial step in treating a pneumothorax, it's placing the patient on oxygen. Then the next question becomes, your disposition. Is this somebody that, can be observed, can go home? Do they need to be admitted? Do they need a chest tube? Do they not? If it's a small chest tube, less than 15% or so, they really don't have any symptoms, then typically you can place these patients on oxygen and they don't need a chest tube. If they do, typically this is like a traumatic situation. So a patient from a car accident, loss of breath sounds on the left side following a motor vehicle collision, they're going to need a chest tube. They got a history of COPD and they've collapsed along, they're in respiratory distress, they need a chest tube. Or if this is getting bigger, so let's say that you have a small pneumothorax, you put them on oxygen, you repeat the chest x-ray, it's gotten bigger, you need to put a chest tube in. Most questions will revolve around where to put the chest tube. So in this picture here, you have the lateral edge of the pectoris major, you got the base of the axilla, you got the lateral edge of the latissimus dorsi, and then fifth intercostal space. And that's where you're aiming for there, and it'll be above the rib in the first intercostal space, typically how that goes. The most complicated, or the most feared type of pneumothorax is what's called a tension pneumothorax. And pretty much what happens here is you get this ball valve effect where air is being released into the chest and it can't get out, and so it slowly builds up the pressure. It pushes everything to the other side, and so that's where you'll have a question stem that says, sudden respiratory distress, you're having loss of breath sounds on one side, trachea is deviated to the contralateral side, whatever it may be, they're becoming unstable. And then on that part, you'll have place a large bore needle at the second intercostal space as your first step if they're becoming unstable. Remember that a tension pneumothorax is also one of the 5 T's in a PEA arrest. And so they could come at this in a different way, saying that the patient was found down, they were in PEA arrest. You then take the patient on exam, you have, loss of breath sounds on one side. They're trying to get out a tension pneumothorax, and it needs to be intervened upon. Other than that, pretty straightforward with pneumothorax questions on the exam. Any questions, let me know. Otherwise, that is all. Thanks, guys.